For Session Update, I'm Shannon Lurkey. Earlier today, Senate Republicans announced their plan to push for low, transparent pricing for healthcare services. Here's that state capitol press conference from earlier.
Well, good afternoon. Before we start, how about those Timberwolves? Just say.
Overtime.
So yesterday we did our topic was mental health, advancing Minnesota. What do we do about some of the mental health issues? And we laid out a plan that we believe can truly help Minnesota in that area. At the end of last session, when we finished up all the things that we did for tax relief and for a transportation bill, real ID, education reform, and more, it didn't seem like there was a lot left to do. But one of the things that we knew that we wanted to do was focusing on how to drive down the cost of health care. And we wanted to take a unique approach. We had a number of seasoned legislators that I think do a fantastic job related to healthcare costs, all the issues related to HHS. But unique to the Senate, we had two new senators that were medical doctors. So we had medical professionals in addition to a chiropractor, in addition to people in the insurance field. And we said, we've got some extra time here. Let's form a subcommittee on how to drive down the cost of health care. And so we had Senator Jensen lead that. We invited Senator Klein and a group of senators to work throughout the interim, and they did. They did a great job. And as a result of that, we've started to roll out some things that we can actually do to begin to bend down the cost of health care. And so with that, I'm going to turn it over to Senator Scott Jensen, but thank you for coming and hearing what we're going to do next.
Hey, Doc.
Thank you, Senator Gazelka, and thank you, folks, for coming. Indeed, I would like to say thank you to Senator Gazelka and the leadership team for the vision and commitment in creating the Senate Select Committee on Healthcare, Consumer Access and Affordability. And I did rehearse that to say it right. And I'd also want to say thank you to the members of that committee, Senators Wickland, Klein, Frentz, Sparks, Rosen, Draheim, Pratt, and Kiffmeyer. And I'd be remiss if I didn't say thank you to the leaders of the HHS mission here at the Capitol, as Senators Benson and Abler and Lori do so much to champion the cause of what has to happen in health and human services. In all candor, I tell you, there is no way in the world I would want Senator Benson's job. Virtually daily, she's presented with the worst kind of mismatch between requests made to her and dollars available. There's just no way to make it work. So hats off to Senator Benson. In 2017, I think you can say that the individual market was in need of CPR, and the insurance rebate program and the reinsurance programs did indeed stabilize the situation. But that was 2017, and that was just the beginning. Later in 2017, the Senate Select Committee began to meet, and we went deep into the weeds on a variety of areas, but we focused especially on transparency, pharmaceuticals, and choice. Those were things that we thought were really important. Today, we're focusing on transparency. Why start there? Well, quite honestly, transparency needs to become the juggernaut of transformational change in healthcare. Otherwise, what the system is going to look like down the road 10 years, I don't think any of us could know. Transparency can be the start that, if you will, re-engages a patient into the system. Currently, we don't have a patient-centered free marketplace because we're not giving it a chance. How can you ask people to be responsible in terms of how they use their healthcare dollars, how they steward their resources, if we won't tell them what the price is? It makes no sense. If a person is going to go to the pharmacy and pay $40 for an antibiotic by using their insurance card, but not be able to be told by the pharmacist that if they just paid cash, it would only be $20, that makes no sense. If a person is going to pay $90 at an office visit here, and down the road it'd be $130, and we're not going to let them know the difference because we're going to use gag clauses and rigid regulations in contract language. That doesn't make sense. So the bills that we're going to be presenting over the next few weeks on the Senate floor and hopefully moving forward will deal exactly with that. We're trying to make prices transparent. I think this will make some larger corporations and larger stakeholders uncomfortable, but in the end I think we'll all see that this is a good thing. We'll actually probably get to a point at some point where we say, how could it have been any other way than to let people know what they'll pay or what physicians are going to get reimbursed? And lastly, why does it matter? Well, if you have a deductible of $6,000 and you're not going to hit it that year, and you're going to go down and get a Wart frozen, it might matter to you if it's going to be $100 or $170. But if physicians can't tell you the price that your insurance company is going to pay us, then you won't know what you're going to be credited for and ultimately will have to pay. Those are why these kinds of things matter. Having said that, today is one step. It's one step towards helping patients be their own best champion, because patients can and should be their own best champion. I think I've spoken enough. I'd like to have Senator Rich Draheim, who's been just a workhorse on the issue of transparency in healthcare. I'd like to have him present. Senator Draheim.
Thank you, Senator Jensen. If someone would flip the chart over for me, thank you. More than ever before, patients want to know the charges associated with their health care. As they take on a greater share of their health care costs with higher deductibles and copays. We are accustomed to quickly comparing prices for any product, online, in the store, et cetera. So I see no reason why healthcare should be any different. Just like you receive an estimate for an auto mechanic if you take your car or truck in to get an estimate, medical procedures should be the same. My bill or bills aim to have transparency in healthcare costs, not only for the medical industry, but for the facilities, for the hospitals and clinics. There's two different bills we touch on that, and the whole goal is to start the process, like Senator Jensen said, of having families be in charge of making their healthcare decisions. And I would like to thank everybody that Senator Jensen mentioned, the leaders, HHS, everybody on the committee, but more importantly, the organizations that came together to work on these bills. There was a lot of buy-in, a lot of give and take. The bill isn't exactly the way we envisioned at the start of the process, but I think the end result will help. So I appreciate that, and with that, we'll take questions. Thank you.
Does this apply to any medical, anything to do with medicine, prescriptions, just every procedure, every doctor, every nurse practitioner, everything?
Doc, do you want to field that? Sure. Okay, thank you.
Thank you. Thank you for that question. The chart that you're looking at actually applies to primary care clinics. And so in the past, we've already had language in statute that allows patients to get a good faith estimate within 10 days and things like that. But we wanted information to be more immediate and more transparent so that when you walk into a clinic, you can say, can I look at your price list? And there's certain lessons that we would hope that people would glean from this. If you look at the top level, the intermediate office call, that's a sore throat or a sinus infection. Oftentimes, an office will have a retail charge of $150, and quite honestly, the only people that pay anywhere near that are work comp and motor vehicle accidents. But the cash pay, most clinics will provide a discount for people that are paying cash, and they'll usually discount it close to what a commercial insurance would be. And then you have your medical assistance and your Medicare. So what would a person learn by looking at this chart when they go into perhaps the clinic that I work at? Well, they might learn that the same procedure or same service, medical assistance patients pay $50 and commercial pays $105. So there'd be a conclusion, gee, I guess commercial insurance is subsidizing the medical system, and that would be true. You'll see that Medicare is $75, and you say, okay. Then you might ask the question, gee, is that why this clinic chooses to have appointments for medical assistance only in this tight slot of schedule availability? And I don't like that that's done, but that is done in some clinics. So there's a lot of lessons to learn when you start seeing the prices. That, I think, is the value of transparency, but this is basically for outpatient clinic procedures.
And the bills only apply to that, outpatient?
No, the bills are much wider than this. This is just one amendment that Senator Benson helped us amend onto Senator Draheim's bill.
So how broad is the
package of bills?
Yeah.
The package of bills gets to disclosing facility fees so that if when you walk into an office, if the office happens to be associated with a hospital, if you don't know that, you might expect a $120 charge from the physician, but you would be surprised by the $250 facility fee. It gets at that. It gets at transparency in regards to clinics. It also gets at the transparency that I mentioned earlier in regards to the gag clauses. So if you go to a pharmacy and you pay $40, you will now be able to be told by the pharmacist that, you know, if you just pay cash, it's only $20. So I think it hits pharmacies, it hits clinics, it hits facility fees, and we already have language in place regarding hospitals and things like that.
So it looks like several of these are requirements. What are the teeth or the punitive measures if they don't do it?
That's a great question. In terms of having teeth, I think I'd have to pass on how that would actually be enforced. I would assume that DHS would be the enforcers on that, but if you don't mind, I'd love to defer to Senator Benson and see if she would take a crack at that. Would you help? Thank you.
Most of these provisions fit within existing requirements. They are complementary or in the same section of statutes, so the same enforcement mechanism, a commissioner's authority in either Commerce, DHS, or MDH would be the appropriate recompense for these violations.
And could there be pushback that this is more government regulations?
I think there's always a balance between, for example, contracts that might not be in the public's best interest, that say a pharmacy isn't allowed to tell someone that they could get a better price. That's against the public interest, and so there can be a back and forth, but ultimately what we're trying to do, what Senator Jensen, Senator Draheim, and the rest of the HHS team is trying to do, is help consumers understand and engage. And if you look at an office call for retail office call, what if there's $100 difference or $75 difference between two clinics that you would equally choose to go to and you have an HSA? How empowered does that make you that you can now see this? And so it's about empowering consumers. And yes, there are some people who are going to be a little frustrated with the change, but ultimately Minnesota is going to be better off the more people understand the cost of care.
And on fiscal note, does DHS need more money to enforce this then?
No, they already have a regulatory structure in place.
Okay.
And why would the company, retail insurance, why would they not want to post these prices? And we hear in the food industry, for example, that manufacturers don't necessarily want to put the calories on the front of it.
You know, the only feedback that I heard was that our commercial insurance, there's so many different commercial carriers, like say maybe a dozen at Dr. Jensen's clinic. That's an average. We had to give in a little bit to some of the industry players. We were hoping to have that a little more specific. But I think it's a starting point, and I think that's the important part. It starts a good conversation, and I think asking for a good faith estimate on a procedure is wonderful, and there is some already statutes in place that we can do that, but there was no timeline attached to it. So I heard stories of people waiting 90 days to hear back on a good faith estimate on a procedure, and this tightens that up a little bit.
Is there perhaps,
Yeah.
If I could, I'd like to take a crack at that one as well, because that was a frustration to me and still is. But this is just 2018, and there's more work to be done. Basically, your large insurance carriers don't want their prices known if they're going to go to clinic XYZ or ABC, because they may be different, and that affects how they negotiate with these clinics. Generally, a small clinic, an independent clinic, will have very little leverage when it comes to negotiating contracts. But a larger clinic will have much leverage, so they may well get paid a double. So at our clinic, where we have just 4 providers, we may get $75 on a service, while a larger clinic might get $140. And I think a lot of insurance companies were worried that there would be a race to the top and say, well, if they're getting that, we want that as well. And so they were worried about disclosing that would weaken their negotiating position.
One follow-up. How many procedures would this cover? Everything that's in there? And
The bill that has the 25 most common procedures and 10 most common preventive procedures, that's been amended onto Senator Draheim's bill. That has 25 and 10. But there already is language in place where you can get a good faith estimate on virtually any health care service that you anticipate receiving. It's just that it's not as prompt or as quick.
Senator Jensen, there have been multiple attempts at transparency in this area that haven't gone very far. Do you expect the lobbyists for the healthcare industry and the insurance companies to fight this again?
Have you ever seen such an attempt take place with Senator Gazelka, Benson, Abler, Draheim, and Jensen right there with all these people? That hasn't happened before. This is a new day.
Murderers Row is
Strike that from the record.
have the microphone there. Let me ask this. Is there perhaps an unintended consequence with this is to raising the price of health care by requiring another regulation among clinics, and to basically administer this, to have kind of another layer of administration?
They already have to, and they already have the numbers. You know, they have the codes. That's what the numbers are on there. So
I think
You're saying it's easy to do, they're just not doing it.
I think that's correct. And I think the legislature, we're saying basically the Senate caucus, and I think the House is saying the same thing. We need to push it because this is important. This price transparency will be the thing that helps transform the way we use healthcare services. We all need to be involved. We all need to be the best stewards of how we spend our dollars. And I had an MRI about a month ago for back pain. And I sure as shooting, I got on the phone and I said, okay, what's it going to cost me? And I checked it out. And I got anywhere from $3,000 down to $800. And I chose the one that was just a little above 800 because it was closest and most convenient. But I shopped. And I think that's what we should do, whether we're talking about mammograms, colonoscopies, any of the elective things. Obviously, this bill does not get at some of those critical things where when you have chest pain and you're going into the hospital with potential heart attack, or you're going to the emergency room because half your leg's been cut off. Those kind of things, you're not really going to have much negotiating power, and you're not going to ask, could I see your list, please? But what we're trying to do is we're trying to stop the insulation that's gone on for too long. This started in the 70s when we put a $10 copay in, and as soon as someone paid $10, I know they had no more skin in the game. They say, shoot 'em out. Let's do the works. I know I got a hangnail, but I wouldn't mind a chest x-ray. We got to stop that thinking.
Well, let me follow up on that, because when we go into the pharmacy, and you use that as a great example, that the pharmacist tells you, well, here's what your insurance cost is. And most of us who are fortunate to have health care coverage are doing the copays with our pharmacies these days. So mine is a $25 copay. So that's what I pay. And what you're saying is that the doctor or the pharmacist should be able to say, well, if you paid straight out cash, that's just $15 in an example like this. But a lot of times, are you talking about the copays that we pay or what the insurance pays? When this, because if you have your insurance, is there really any incentive for the consumer not to automatically go with what the insurance cost is?
There are several factors you have to consider there. First off, the PBM, the pharmacy benefit manager, often will have a contract with the local pharmacy. So it may be a $40 charge if you use your card, say a Blue Cross card, and it might be $20 by cash, but the $20 cash then may not go towards your drug deductible. It depends upon the contract you have. And then the PBM oftentimes will come back and they'll say, oh, that $40 you got, you don't get to keep that. We need 12 of it, and that's called a clawback. And so the pharmacist may take $40 from you because you use your card, but they wouldn't necessarily retain that $40. And the $20, the cash pay, generally the pharmacies would just keep that $20, and they may well have a $16 payment for the drug itself, and so they may profit $4. Those are just example numbers.
Would this apply to the situations where I think Optum got some negative coverage around the country for adding surcharges, or they call them clawbacks, where they actually charged more for a drug, patients more for a drug than it would have cost, out of pocket. And there was a lot of investigative reporting done on that, and that's where some of the gag rule stuff came in. Would this gag rule bill apply to those situations, or just to situations where merely the retail costs, the out-of-pocket costs, cash costs is cheaper?
That's an excellent question, and there was a bill that hasn't been able to advance as of yet that got specifically at the clawback so that the pharmacist would indeed share with the patient what they will end up receiving after all the net is done, so that if they get $40, they'd say, well, we paid $16 for the drug, we get to keep $6, but $18 is going to go back to the PBM over the next 3 months.
Is it legal for clinics to have this now?
If the governor signs it.
Okay, no, now, I said.
No, it'd be a violation of contract. My contract I signed with Blue Cross, it has language right in there that if I do something like this, I would have broken the contract and I would be at risk of losing the largest commercial payer I have in my clinic.
And if this passes and signed, would these go online so I could sit at home and compare?
They both go online, and there'll be a menu at the office at the front desk.
Why didn't the PBM bill advance, do you think?
Excuse me?
Why did the other bill, the one that's there that did not advance, why do you think it didn't advance?
These are complex, and I think stakeholder buy-in is important. A lot of times we end up trying to do our best, and we might have some sort of a perverse incentive that we created. So I think on some of the bills we say, yep, definitely move forward. On others, I think with the expertise of some of the more senior senators, I think they will say, you know what, we better take another look at that and see if we need to give that a different shape.
If these bills become law, what do you expect the outcome to be?
I'm excited about the outcome. What will happen is we're going to start having patients engage on a very specific level. Certainly over the last 20 years, we've seen engagement on a broad level philosophically. Is healthcare a right or is it a privilege? Those kinds of things. This is going to get right down to the brass tacks. And the same way that you go to Target and you buy your over-the-counter medicines, or you go to perhaps a GNC and you buy your supplements, you're going to start looking at prices. You're going to know that you're getting honest information. When you go to the doctor's office and say, gee, I have an HSA of $6,000 that I could use up, but I just as soon be as frugal as I can. It's just a wart being frozen. I'm going to go here because they only charge $110 and set it on their thing at the front desk. And over here it'd be $170. I think it's going to start a process that's going to be really healthy for all of Minnesota.
But is freezing a wart going to be the same in your clinic as every other clinic?
Absolutely not. You could literally go anywhere from this example. I use some of our charges, but our commercial insurance, we get paid about $150 to freeze a wart. And there'll be some clinics that they'll probably get in excess of $250, and there'll probably be several clinics that'll be cheaper than ours as well.
I'm not talking about prices, I'm talking about how you do it.
Technology.
Like, are you going to do it slipshod, and the guy down there does it better, and so you charge less and he charges more?
Freezing a wart is fairly straightforward. It's pretty much,
For all these?
I mean, we don't even use anesthesia.
Top 25?
What's that?
Freezing a wart is top 25?
For some clinics, if you're a dermatologist, perhaps.
And what is it in your clinic? Do you know
Would it be, what place? No, but I'm going to guess freezing a wart's in our top 25.
Did you bring some liquid nitrogen with you today?
If I said yes, would you allow me to try it right now?
Earlier this year, we saw the House pull the penny a pill tax for opioids out of their bill under pressure from the pharmaceutical industry. What do you think what's your level of confidence that the legislature as a whole is willing to take on some of the people who have a vested interest in protecting this current system?
I've spoken enough. I think to hear from Senator Benson or Senator Gazelka would be a better responder.
There is a myriad of issues that we can work on, and so we made a decision, let's find out the ones that we can get to, that we can agree on, that we can actually pass and move the ball forward. And none of them come with everybody thumbs up, we really want to do this. But in any bill that we're trying to pass, you have to build a big enough coalition to make it happen. It doesn't matter what the issue is. And so healthcare costs are even more complex. And so I appreciate that the people that were on the subcommittee and all the chairs that we have in the Senate are listening to everybody and then finding a way through that. And so the ones that we waited on, that doesn't mean that we aren't still trying to do them. It's just that we want to give them more time to get more buy-in to move it forward. And so this is the beginning of hopefully a new way of driving down the cost of health care. Senator Benson, do you want to say anything on that?
Are you saying that the penny a pill is not moving forward? I mean, I heard you say two things, I think, but.
Well, hopefully it didn't talk out of both sides of my mouth there.
That's what I meant, but you.
No, the penny a prescription is one of the ways that we can talk about funding opioid abuse. I've said that we are going to find a way to move forward with legislation and funding for opioid abuse. I don't know that it'll be the penny a prescription. There's enough pushback that could be more difficult in the end, but it really, to me, it really doesn't matter where we do the funding. Right now, the pharmaceuticals through other fees pay into the state general fund around $250 million a year, so I'm not worried about are they paying enough. I'm concerned about are we going to address opioid abuse. And we've brought them to the table. I appreciate what Senator Rosen has done. She's done a great job including them in saying, we want you to help us find some solutions. And that process has begun. And I'm excited to see the different things that we're actually bringing forward. But that wasn't the focus of where we're at today, so I don't want to steal Senator Rosen's thunder, but we are making great progress in that area as well. So with that, I think we're going to wrap it up because we want to leave the focus on this, but thank you for coming.
Senator Benson, what's the status of these bills? You've heard them all. There you go.